Top Bed Talk.
This piece is presented by Professor Sandy Jack, PhD, consultant clinician scientist in the Anaesthesia and Critical Care Research Unit at University Hospital Southampton NHS Foundation Trust. She's also an honorary senior lecturer at the University of Liverpool, University of Southampton and University College London. Have a listen.
Thank you very much for inviting me to talk at this auspicious meeting. Thank you to my chair, ladies and gentlemen. I'm going to talk about models of prehabilitation and the Southampton experience. So the things I'm going to cover today are our Fit for Surgery studies. The Fit for Surgery Consortium is director is Professor Mike Grocott, and I'm co-director. Talk about the e-studies that Mike and others have been working on with me for the last 12 years, our key findings, our studies, our recent studies and studies in setup. So our Fit for Surgery studies include the slide at the top here is our initial trial, which was Malcolm West's PhD, and this was looking at the effects of neoadjuvant chemoradiotherapy and physical fitness and mobility in rectal cancer patients. We then went on to receive NHR funding to do a randomised controlled trial, which is looking at neoadjuvant chemoradiotherapy in the same cohort, and this was called the EMPOWER study. And then we went on to further investigate other cancer types, which we looked at a Fit for Surgery trial, which is called EMBRACE, and this is exercise regimes before, during, and after advanced cancer therapy, and this is in non-small cell palliative lung cancer patients. And finally, ENCOURAGE, which is exercise training before, throughout, and during neoadjuvant chemoradiotherapy or chemotherapy in patients with esophageal and gastric cancers. So our key findings, we were the first group to show that chemotherapy, particularly platinum-based chemotherapy, reduces your physical fitness. The slide shows here that physical fitness is significantly affected by chemotherapy or chemoradiotherapy. We performed a cardio-pulmonary exercise test prior to the patients starting chemoradiotherapy, and these were in upper GI cancer patients. And then they had their standard course of chemotherapy or chemoradiotherapy. And then once they'd finished, we waited a period of time of around 4 weeks and repeated the cardiopulmonary exercise test. There's a significant fall in their VO2 at anaerobic threshold, and this was also shown in the VO2 at peak. And this fall is not only highly statistically significant, but is clinically significant, of a fall around 1.5 mils per minute per kg. If I was to say to you, go out and increase your physical fitness that amount, you'd have to train as if you're running a marathon. Moreover, these patients, before they had chemotherapy or chemoradiotherapy, were low risk, and now after their chemoradiotherapy, then they're high risk. Moreover, we also showed that the physical fitness was associated with outcome, and that when this Kaplan-Meier plot shows here, that when we split the groups into the low, medium risk, high and highest risk, that baseline physical fitness was related to mortality at 12 months. In fact, baseline fitness over the 12-year survival period of the odds of mortality being fourfold higher in the patients that were deemed to be the highest or the high-risk group. So not only does chemoradiotherapy and chemotherapy, particularly platinum-based, reduce your physical fitness, it also causes significantly poor outcomes and increased mortality. So we went on to show in patients with rectal cancer, and this was Malcolm West's PhD, that also the chemoradiotherapy significantly decreased your physical fitness. So this graph here shows VO2 at anaerobic threshold, pre, post, week 3 and week 6. This was a 6-week exercise training program in hospital, structured, responsive, HIIT training over the period of a 6-week course. Patients came in 3 times a week, and we had an adherence of 94% and no adverse events. We also continued to record the physical fitness and repeat cardiopulmonary exercise test at week 9 and week 14. We showed, not surprisingly, again that the physical fitness fell significantly after they had their chemo-rad, and the control group then continued to fall at week 6, being significantly less fit and higher risk than the exercise group. The exercise group increased the physical fitness within a 3-week period, so you don't particularly need a long period of time to be able to have a significant effect on patients' physical fitness. And then at week 6, which was at the end of the interventions, there's a statistically significant difference between the exercise and the control group, and the exercise group remained or they returned back to around their baseline level. The exercise group then had a residual exercise response up to week 14 where they underwent surgery, whereas the control group continued to fall significantly. And as I say, it's not just the fact it's physical fitness. These patients started off as low risk, they became high risk with chemoradiotherapy, and then continued to fall during the course of having chemoradiotherapy, and then would end up needing more intensive care post-surgery. We're also the first to show in humans that exercise is associated with decreased tumour regression. So what we've shown in this graph here with the control versus the exercise, and again in the same patient cohort, is that the exercise group had a favourable outcome. So there was 22% of the patients in the control group that had poor TRG, so they had an unfavourable outcome compared to 58.3 in the exercise group. So therefore, there's a significant improvement in the patients in the exercise group with better TRG score and tumour outcomes. This translated into YPTRG, which is histopathological findings of the exercise versus control of 0.05 p-value. And when we looked at the people that had responded to the exercise training versus the people that didn't respond to the exercise training versus control, the p-value was stronger. So we've gone on to look furthermore about how we can translate prehabilitation interventions into more standard care and do more pragmatic trials to align with a long-term plan. So this comprehensive model of personalised care that looks at the whole outcome of patients under this crisis of obesity and poor physical fitness and people not being able to exercise or not having time to exercise, the government and NHSE have set out to try and address these issues. And they have suggested we can do universal interventions for the whole population, and that's mainly advice, more targeted interventions, even with people that have long-term physical mental conditions, and they suggest there's around 30% of those patients will need that intensive targeted interventions, and around 5% of patients with long-term complex conditions will also need more specialist interventions, but that we should be able to work together in a shared decision-making manner to improve patients' physical, mental and metabolic health. So in 2019, we launched the Prehabilitation People with Cancer Guidance. This is in collaboration with the NIHR Cancer Nutrition Collaborative and the Royal College of Anaesthetists and Macmillan. There were a significant number of Southampton team that were involved in the guidance. Professor Mike Grocott co-chaired these guidance process with June Davis from Macmillan. And there are a number of us that were either chair or co-chair on the subgroups. This was predominantly to look at how we could effectively screen, assess, and then perform interventions that are effective and needs-based and personalised, and then monitor and evaluate the outcome. This triangle then represents our translation from the long-term plan and the personalised care model of personalised care into a triangle that's appropriate for prehabilitation, with the universal level being advice or supported advice applicable to anyone with cancer, the targeted being more around people with cancer that have acute or chronic conditions, and then the specialist being applicable to people that have more complex needs. This triangle is not as easy as it seems because you can go up and down the triangle, so start off with as universal, then have chemotherapy need targeted, or then have prehab and then go back down to universal. It also is complicated because you may be universal for nutrition, targeted for psychological support, and specialists for exercise. There are 64 combinations in total of what you could receive within this triangle. Also, there is thought now that not only can you move up and down the triangle, but between universal and targeted, there's soft targeted, because you can deliver soft targeted advice with support from telephones, virtual clinics, the rest, to be able to deliver more targeted needs-based interventions. So Southampton, known for their perioperative medicine expertise, and have a critical mass of experts in the field in prehab, cardio-pulmonary exercise testing, and the list goes on. So pre-op Safefit, which we'll go on to talk about, is our new trial that goes across the whole of the pre to post-surgical range. We have a variety of trials, so Wesfit, which I'll go on to talk about, Inspire, which is led by Denny Levitt as the CI, that's looking at inspiratory muscle training to reduce pulmonary complications, and Capoeira, which is also a trial led by one of Southampton team. P-Quip that everybody knows, Pulsox and Floella, Empress and Emerald. So there's a vast variety of trials and activity happening in the prehab world or supporting prehabilitation. So Westfit is my trial. I'm CI of this trial, and it's funded by NHS England. It was funded as part of the Cancer Transformation Programme, Sustainability and Transformation Partnership. We put this bid in partnership with Wessex Cancer Alliance that was led by or supported by Sally Rickard, who's a medical director now, and Matt Hayes, who is a urology surgeon at Southampton. We put this in for the recovery package, which is a mandated soft prehabilitation package from Macmillan, and for the delivery of Westfit. And we were lucky enough to receive £3.6 million across the two work packages. And we then set up the Wessex Fit for Cancer Surgery trial, fondly known as Westfit. It's a pragmatic randomised controlled trial. It's a study to assess the efficacy and implementation of prehabilitation programme in patients undergoing elective major intracavity cancer surgery, and started off only in Wessex. It's the big 5 or 6 of cancer patients that are undergoing elective surgery. These include HPB, lower GI, upper GI, thoracic, colorectal, and urology, and head and neck. The trial is pretty simple in the fact that it's a factorial randomised controlled trial, but the trial design shown here shows it's fairly simplistic design. And identify eligible patients, male or female patients over the age of 18, and they have to have planned major surgery with or without chemotherapy, neoadjuvant cancer treatments. They need to therefore be on a surgical pathway with or without cancer treatments, with a screening cardio-pulmonary exercise test, and if they pass the screening, then they're randomised to either control, which is standard of care, exercise, which is targeted, HIT training that's delivered in the community, psychological support, which is counselling, and the combination in group 4 is a combination of exercise and psychological support. We do not delay any stopping the clock. It's within the time that the patients have, so the optimal amount of time they have prior to surgery, and this may only be 2 weeks or up to 15 weeks. They have planned surgery as usual, and we follow up post-op. So this is the infographic that shows how the trial works. So it's pre-surgery shown here, that then if they've got 2 weeks only, this is just with surgery and no chemo, and then up to 15 weeks. We delivered this up to 15 weeks, so if patients are undergoing neoadjuvant cancer treatments, and this was at the request of the patients. We suggested that perhaps they only wanted to look at start the trial after they've finished their cancer treatments, but they were adamant they wanted it throughout. So the infographic shown here shows that there's then they go to surgery, and then we follow up post-surgery. So the control group is standard care, exercise is HIT training delivered in the community by a personal trainer with healthy conversations supporting behaviour change. Psychological support is non-directed counselling in a wellbeing centre, and the combination of exercise and psychological support as group 4 with healthy conversations. We've had significant traction in Wesfit to deliver this trial. It's a pragmatic 2x2 factorial design randomised control trial with an sample size of 1,560 patients, that should say. Randomised control study to assess efficacy of prehabilitation programmes across Wessex. We've now been contacted by over 30 NHS trusts to take up Wesfit. They see it as a model that should be business as usual, and we know that it's effective for patients. We've had significant uptake and recruited over about 300 patients to date. This is our track to quarterly time over recruitment, and we were somewhere around here. And at this point, we were going to consider looking at whether we stop this in Wessex because we got such traction, a lot of traction nationally, and start to look at this as a service. However, as we know, we're unable to continue with that at present. So this map shows all the cancer alliances in the United Kingdom or in England, and it shows that we've got 15 out of 17 of the alliances contacted us to take part in the trial. Our grand plan was to continue Westfit. This would be rolling out to the full trial nationally, and then we would stop or we would pause and translate this into a pilot clinical service in Southampton and maybe across Wessex, and then implement alongside the randomised controlled trial. We would then roll out nationally using the Wesfit model and trial as the infrastructure to set up new sites, and then once they completed a number of patients, we would then support implementation of a pilot service in their region or their hospital. And then looking at Wesfit 3, which would be an innovation platform, we were doing extremely well, had significant traction, had lots of discussions with NHSE and I. It's a large amount of money we needed to be able to facilitate this, and we, as I say, we were having very encouraging conversations. This is all delivered in gyms and wellbeing centres. So as of the weekend of the 19th of March, we had to pause the trial. We paused before the gyms closed. There were 9 patients on the trial, and we had to ring all those patients up to tell them they could no longer be part of the trial, and that we were closing and pausing the trial for, I don't know, we indeterminate amount of time. The reaction was amazing. They were completely devastated, and one patient said that they would rather risk the dreaded lurgy, although we didn't know how dreaded the lurgy was going to be at that time, than risk not being fit enough for their cancer treatments or their surgery. So because of that, it was a call to arms. I thought there's no way that we can't support these patients. Imagine having a new cancer diagnosis, being in lockdown, and having all your cancer treatment either changed or paused. So call to arms. I spoke to our Macmillan lead, June Davis, who led the guidance with Mike Grocott, and said we have to do something about this. And as a result of that, I'm very proud to say we've set up virtual clinics to deliver universal interventions to maintain and improve mental and physical health in people with cancer who are following social distancing guidance. And this is a COVID-19 targeted trial. So it's with support from Macmillan, who have provided some of the funding. Cancer Rehab Trust, they are a level 4, they train people to be able to deliver cancer rehab. They're experts specialise in cancer and also other chronic conditions, and their personal trainers or instructors are at level 4. And also Wessex Cancer Alliance supported us. As I say, it's virtual clinics, they're complex interventions, and it's to improve mental and physical health in the patients, following the social distancing, shielding guidance. I remember in early April listening to a briefing that Professor Chris Whitty, our Chief Medical Officer, gave. He mentioned exercise 10 times in his 15-minute briefing, and he emphasised significant benefit of exercise for all people, and he said that this may be challenging for those self-isolating and even more so for those that are highly vulnerable and trying to shield in their own homes. We know it's going to have a devastating effect on the economy, on health per se, on surgical services, on cancer services, and the mental consequences, social distancing, isolation and loneliness is going to be a tsunami of mental illness. What can we do about it? So it's really hard to deliver virtual clinics, particularly in the complex interventions. We know that home-based exercise training has not been terribly successful to date, with very poor adherence of only around 8%, whereas all of our trials have had around 96 to 87% adherence. However, we must do this and we must do it right. There was a review that was from Julie Silver, who's an expert in rehabilitation, suggesting prehabilitation could save lives in this pandemic. There's also a recent Lancet paper talking about the effects of not just cancer, but COVID and cancer, and the outcomes and effects of having cancer and COVID, but also having cancer per se. And there's an increase in 30-day mortality, and outcomes of patients are going to be poor. So treatment plans for cancer patients are being revised. We don't know when they're going to go back to any semblance of normality. We don't know when we can reopen Westfit, as the gyms are still not open. There's a new report from the World Health Organization that estimated over the next 6 months there'll be up to 60,000 cancer-related deaths, and approximately 12,000 participants will suffer illness or undergo invasive treatments due to loss of cancer services that they may need have not have undergone. So there's a suggestion that the longer medium-term outcomes of COVID in cancer, that the deaths may outweigh actual COVID per se. People are vulnerable, they have underlying health conditions, they have a letter from Boris Johnson saying they're high risk and they're extremely frightened, which is very fear-inducing. They're self-isolating, shielding, so maybe in their own house, shielding from their own families, trying to be fit and active and continued so that they could undergo their cancer treatments. The psychological impact of increased anxiety and feeling stressed and angry is huge. We already know from Macmillan there's a significant increase of calls to their support line with lots of indications of psychological impact of self-harm. We also know that COVID per se may cause dementia, and the knock-on effects of being in lockdown, having cancer and not being able to receive your treatment is only going to augment that. So older patients that are already social isolating, they feel extremely lonely and will have worse mental health. So Safefit is to develop a cancer-specific program for physical fitness, physical activity, support for optimised nutrition, and psychological support with access to resources and apps, as well as behaviour change. It's available to anyone in the UK with a cancer diagnosis or suspicion of cancer. We do rigorous screening because we called it Safefit, so there's rigorous screening prior to consenting or taking part in the trial, that we screen for any comorbidities and inability to take part in exercise, for overt disease-related malnutrition for the nutrition side, and any serious mental illness, including self-harm. We have strict, rigorous escalation plans for any of the above that we find that patients need further support, and we continue to screen throughout the process. We look for COVID status, so we ask the patients for their COVID status, and there's a questionnaire at the beginning and at the end. If they have COVID or are suspicion of COVID, we ask them to refrain from exercise or pause their exercise for 14 days. It's 6 months personalised support. This is basically supervised home-based interventions or complex interventions. It's up to 1 month. For the first month, it's up to 3 sessions per week. For the next 2 to 3 months, it's 1 session per week. And then we tailor it off for month 4 to 6 of only 1 session per month. It's completely needs-based, it's pragmatic. They may have 1, 2 or 3 interventions depending on their needs. It's delivered by telephone in case there is the digitally naive, the video conferencing, individual sessions or group as requested. The inclusion criteria is male or female participants age over 18, as I say, with suspicion or confirmed diagnosis of cancer. The only exclusion is that people that are unable to consent because they may be able to receive one of the interventions, if not all, and that is still eligible for the trial. The sample size is 1,100 and the groups are confirmed COVID, suspected COVID, self-isolation or none. Primary objective is to look at these complex interventions using virtual clinics to improve physical function as measured by the EORTC, which is a European cancer-related validated questionnaire, and improved physical function is a subset of that questionnaire. Secondary objective is to look at virtual clinics and complex interventions to improve emotional function, quality of life and patient activation measures, behaviour change, and most importantly, health economics. Our exploratory outcome is overall survival and adherence to interventions or advice. We opened the end of May. First patient was recruited in 3 days. It is all self-referral via the Macmillan platform, and we've now consented 35 patients. We've only been open a short period of time. It is clearly something that patients want, and we think we're going to be inundated with referrals, but we hope that we will be able to support the patients throughout the trial and beyond the trial. Positive feedback from one of the first patients we spoke to. She said, "This was a call I needed. It's given me a huge lift and I can't wait to share how great this service is with others. Thank you." She said she's been feeling very low and isolated, and she even did her hair today for the call despite being not able to see the person who was calling her on the phone. I have to say there's been many hours trying to write this protocol, get it through ethics, and just that one statement from the patient makes it all worthwhile. We're all, as a group at Southampton, completely passionate that this trial at the moment is the new norm and we need to support it and continue. It is a trial, but it's an evaluation trial that also exists within a service, a pilot service for Macmillan. We want the service to continue beyond the trial, and we're trying very hard to get the funding to continue with this, and are in conversations with commercial partners, pharmaceutical industries, various grant bodies, NHSE and I. We also hope to talk to NIHR to look at evaluation, because evidence, data and intelligence around the effects of COVID on patients with cancer is invaluable. And we hope to be able to put a grant in to look at all the other services or trials to evaluate robustly all these effects. And we really hope that in maybe the near future, this is a business as usual commissioned service. Trials in setup, so we also want to use the Safefit model of trial design to do hospital to home rehabilitation using hubs and virtual clinics to deliver universal and targeted interventions to improve mental and physical health in people recovering from COVID following ICU stays. So using the same model. Andy Bates is leading on a feasibility trial looking at post-critical illness PSD, using what they use for the soldiers, online eye movement desensitization. And lastly, we're working closely with our cancer science team at Southampton, with Malcolm West leading, Tim Underwood, Alex Menazami, Mike and myself, to further investigate mechanisms of the tumour host signature using Safefit and Westfit. So the importance of looking at host and tumour in response to the fact that there seems to be an association with improving physical function and fitness in the host translates to improved tumour outcome. And in conclusion, the combination of Wesfit, Safefit and all the other trials and services that are happening across the UK and beyond should really be our business as usual service. So particularly in these times when people need this support, this should be our prehabilitation medicine service. So the guidelines and position papers are all sitting in the right place for us to be able to start thinking about service models, and this is business as usual and commissioned services. So in conclusion, for the Southampton section, apart from a little bit about funding, is our absolute end game is, together with Mike Grocott, Denny Levitt and the whole critical care perioperative medicine team, we're looking for a physical space within Southampton to be able to deliver a specialised centre for evaluation, prescription and treatment. This will be personalised assessment, individual prescription, including exercise, nutrition, psychological well-being and evaluation of comorbidities. With exercise training, it may be in hospital for inpatients. This centre will be the first business as usual, hopefully commissioned service that there is within the UK that's a sustainable model, and we hope that this will also be an academic centre. So we need further funding. There's a 5.5 million loneliness bid application we put in with Macmillan in partnership for 1 million. And I'm very pleased to say that we put in a €6 million EU Horizons grant that's looking at complex conditions and comorbidities that we've included, or they've included, Safefit and Wesfit as part of the bid. And they're actually saying that in this environment, that Safefit may be their USP because it's their only COVID-related trial. I've got a whole host of acknowledgements. It's 12 years of work that's got us to this point, and the ability with a critical mass and experts and a fantastic team in Southampton to be able to put Safefit together in a very short space of time. And I'd like to thank everybody sincerely. And these are all the supports, that's the network that we've got for Safefit, including the Royal College of Anaesthetists, the Macmillan's Survival Research Group, the Centre for Perioperative Care, Southampton University, Southampton Trust, Rehab, Wessex Cancer Alliance, and Macmillan support, of course. Thank you so much for your attention.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.